So much, sir. Good afternoon, everybody. We've had a lot of talks today. We've had varieties of discussions. We've had, great eponymous talks, great original experience. And I was asked by Shantanu that the theme of this conference is gold standards. And I said, okay, let's see, because I personally think that the gold standards go on changing. So that's me. Most of my work these days is now with AO trauma, but I'm not going to be talking about AO trauma. I'm going to be talking about what exactly is a gold standard. How do we apply it to surgery? Because gold standard is a benchmark, something like a standard of excellence, which we use as a reference point. The problem with this is these gold standards change. Gold doesn't change. But when you apply it as a standard in any field, it tends to evolve. And why does this happen? Because especially in surgery or medicine, we have better understanding of the problem. We have better diagnostics and we have better surgical modalities, and the standards could also differ upon where you are geographically. I've had a great talk listened to on total angle replacement. It may be the gold standard in Australia and America, but will it be the gold standard today in India? So all of this influences what we would label as a gold standard. If you come to the foot and ankle, there are many conditions where we try to apply gold standards. And I'll talk a bit about each one of them and see whether we have any gold standards or not. The topic which is one of my favorite is calcaneus fractures, but this has perhaps had the most evolving standards of treatment. If you look at this graphical model, from the 70s, the non-operative red one came down dramatically, some increase in the last 5-6 years. Extensile approach went up, plateaued, came down, and the blue MIS is going up and up. So if you look at comparative, studies, today we know that if you want to apply a standard, in a well-done case, surgery is a gold standard. But that's a generic term. We all know that the best outcomes come after surgery, but what type of surgery? In which case we have to think about? And out of all these surgical procedures, we had this great publication by our secretary, Abhijit, in the Indian Journal of Orthopedics, that perhaps MIS is evolving as the gold standard. But let me tell you, if this gold standard is adhered to by beginners, they may have a problem. It's after experience that you go to the sort of MIS for calcaneus fractures. Even the term MIS is changing. Because what we do as MIS was a sinus tarsi or a percutaneous approach. But now things are coming in with people coming in with specialized angle stable wire things, this is a publication out of Greece, if I'm not wrong, or Italy, where they have this system which uses elastic wires to hold this in place. Intramedullary nailing for calcaneus is coming in. And there are special jigs and special techniques using the same minimally invasive approaches to reduce it, and the nailing is then done with a jig. The good thing about this is it gives you a solid angle stable device. But is it a gold standard for me? Perhaps not. So for the calcaneus fractures, the only gold standard today is perhaps minimally invasive surgery. The fixation type is still debatable. But what is not debatable is accurate reduction and maintaining a three-dimensional stable fixation. Arthroscopy may come in. Along with MIS may become a gold standard. But as I say, the major issue is surgeon competence. If you know how to do it, almost everything is good. We had a great talk by my colleague, Dr. Siddharth, on the talus, and he's become a bit of an expert with his PhD on this. But if you look at the talus, it's a bone which the only distinction is it actually had a car named after it. Hyundai came out with a car called the talus because it was a hatchback. But it has a bad anatomy and a bad vascularity. and a high complication rate. So the gold standard for a talus fracture is accuracy of reduction, if you want me to put it in one word. But there are other things which come into play. Timing of surgery, method of fixation. We used to do K-wire, then we went on to screws. But now today the gold standard for complex fractures is a rigid, stable fixation, which we probably have to achieve by plating. Sometimes on one side, sometimes on the other side. And what about treatment of complications? I won't go into malunion because Siddharth talked about it, but what about avascular necrosis? Is there a gold standard treatment for this? We don't know, and already alluded to you by Siddharth, there are different types of avascular necrosis. Some of them are totally sclerotic, some of them are partially sclerotic. Many of them evolve. Until today or a few years ago, we never knew why they did not collapse, and some of them, they collapse. And we've come out with a hypothesis, which I will not go into detail, about the so-called three-pillar classification based on Herring, which talks about the same things which are happening in Perthes disease. But the gold standard for AVN is offloading. You have to ensure that till healing and to prevent collapse, you make sure that the talus is offloaded. Not vascularized bone grafting, not other things, but offloading. And we've had an experience with many, many cases over time. Let's go to the midfoot. The complex fracture, which we call Lisfranc fractures. This has variable displacements, variable fracture patterns. And that's why when we have a problem like this, you have to understand the complex bony fractures. The gold standard may be medial column fusion and stable fixation. For the purely ligamentous ones, initial a tightrope or something like that may work. So this example of a complex fracture where a medial column fixation and arthrodesis was done, giving rigid stability, and mobile fixation for the lateral side is a gold standard. The midfoot, come more proximally, makes it more complex. Forget the navicular and the Charcot's, the cuboid fractures. I am talking about the midfoot, which has two columns. And you must understand it is like the forearm bones. I've been saying it for the last 30 years now, that if you do not get both columns accurately reduced and kept stabilized, we will get into trouble. We've been publishing since 1999. So perhaps the gold standard is now stable, extended fixations. If you want to use an external fixator or something, but we do not hesitate to use plates anymore. So what I would say for the midfoot is maintain column length. That is the gold standard. Ankle fractures we all see. Huge variety of fractures. Many have associated soft tissue injuries. But do we have a gold standard treatment? Well, if you break them up, like for a Weber C fractures, the gold standard is fix them all, stabilize them, early mobilization. But in Weber B, we have enough data which says the gold standard is not open reduction. Because there's enough data coming out of Australia on the crossbat trial which says that the only thing you've got to do is ensure ankle congruity and fracture stability till it heals. And you get as good results as an open reduction and internal fixation. The most discussed part is the syndesmosis. Everybody talks about, let me fix the syndesmosis, should I fix it or should I not fix it? The word fixing a syndesmosis is now going out of vogue, because there are so many other methods which come into play. And these semi-rigid devices like the Fibulink and the tightrope, they enable physiological motion. And they are gaining traction in use because of this. 30% of syndesmosis with screws across them have problems because of inadequate reduction. And the only gold standard method of reducing a syndesmosis accurately is by looking at it. And that means you incise it from the front, get a good reduction, and then you put in a screw. Because if you cannot do that, do something else. First thing you must understand is you must understand that the ankle is like a ring, like the pelvis, and it's broken. So if it's broken, there are pieces all around, the posterior malleolus, the chaput fracture, etc. So you could do an indirect syndesmosis stabilization by stabilizing these fractures and not need to put a screw through the syndesmosis. And that's what we published last year. Siddharth was part of this. We have this classification of chaput fractures which can be fixed to replace a syndesmotic screw fixation. Example, a surgeon in my hospital, very unstable Weber C fracture. Nothing done for the syndesmosis because we reconstructed the ring and he's come out with a good outcome. So reconstruction, stability is the gold standard. OCD, we see it all the time. No current gold standard. But there's a huge evolution in orthobiologics and our understanding which brings in so many new things. All these scaffolds, etc. are coming, not really working so much. So if you ask me, is there a gold standard today? I'll say probably you could look at chondroplasty, mosaicplasty, and ACI with scaffolds. That is all I can say today. But tomorrow, with the replacement coming more into more vague, maybe things like episealer, etc. would come into play. What about clubfoot? One slide. The gold standard is Ponseti. Nobody has to discuss it, but you have to be sure you know how to do it, and the parents of the patient keep the compliance. The elephant in the room is diabetes, the diabetic foot, where everybody talks about what do we do for soft tissues. There is no doubt about it that when we do non-operative trade, the gold standard is offloading. And how do we offload is things which we need to discuss. Currently, total contact cast is the thing which will work all the time. You can use a temporary boot or something, but this is evolving. We are now getting implantable computerized chips with inflatable soles, which could be put into the foot and they could give you a sort of modulating or changing protocols over time. Charcot's foot, you had an excellent talk by the past president over here. It's a problem. You cannot say that I have a gold standard. But what is nearing the gold standards are these new concepts. Last few years, everybody is now beaming the midfoot because that's the problem. They are adding subtalar fusions to add to the stability. And they are making things which we are calling as super constructs. Add a lot of stability for this bad foot so that it heals. So currently, that is the gold standard. But with time and newer mobile plates, like this new plate which is coming in called the straddle plate, the gold standard may change. Last couple of things which everybody is discussing nowadays. When I was a postgraduate student, my boss told me that for hallux valgus there are about 100 surgical procedures described. None of them works. So I don't know. So the question is, do we have or will we have a gold standard? Now, it all depends. It all depends upon the grade of deformity. It also depends upon other factors like associated problems, like whether you are diabetic, where the deformity is distal or proximal. I'm not going to go into that. But currently, an acceptable gold standard distally is scarf or chevron and lapidus proximally. But as we've heard all today, and as the world is saying, MIS may evolve to become the gold standard. Is it true today or not? I'm going to quote Bob Dylan, because the answer, my friend, is still blowing in the wind. End-stage arthritis. Excellent talk today about total ankle replacement. Fusion or replacement has been a talk for the last 25 years because ankle arthritis stays a major problem about getting function and pain management. Two major things. So fusion, at least in my hands, has worked. We've got better plates, we've got better techniques, We've got even evolving into minimally invasive fusion techniques, which include doing an ankle fusion by arthroscopy. They are good. Downside is arthroscopy has a learning curve, and you cannot do it in deformed ankles with bone loss. However, if you know both, there's no great significant difference. So if you are able to do a well-indicated arthroscopic ankle fusion, for fusions, that may become the gold standard. But now we cannot neglect the ankle replacements. We had problems over time because the previous report said there were no differences because gold standard was the ankle fusion. Now they found that changing to ankle replacements may become the gold standard over time, but a clear answer still awaits us. Diagnostics for the foot and ankle. The future is here, guys. Worldwide, weight-bearing CT is the gold standard. May not be in India. We've got a couple of publications by Alistair Younger and all in our publication, in our journal. It is the gold standard for management or understanding the foot and ankle. Remember, ladies and gentlemen, gold standards will change and evolve. Newer technologies, changing expertise will have an influence. Today's gold standard may be history tomorrow. But at least I can tell you one thing. One of the things which has come to stay is minimally invasive surgery. And it's applicable to many, many things because by adding arthroscopy, virtual reality, everything, this is probably a generalized gold standard for the future. I predict there will be much more in the future. This zone, future zone of surgery was at the Dubai Pan-Arab Orthopedic Conference. They have, every year they have a future zone. You can walk in and see what's coming 10 years from now. So one of the things which will probably be a big deal would be 3D printing. Another thing which could be a big deal, which is already a big deal in knees, could be robotics in foot and ankle. But we should never forget the impact of artificial intelligence. It is impacting every factor of our life, and it will definitely influence foot and ankle surgery. It's already been written about. And I know of centers who are using AI for classifying fractures, for diagnosing fractures, foot and ankle in the emergency room. So remember this may at one stage become some kind of a gold standard. Ladies and gentlemen, evolution is inevitable. Standards will change over time. But it is us, because we are the ones who will create the future. Remember, what will not change is you. You are the surgeon. You have to adapt to the changing technology and upgrade the skills. And it is only then you can talk about Star Trek and see where the future takes us. I thank you for your time.